Okay, let's start. I hope remaining student will come. But today's topic is cutaneous manifestation of HIV. I hope as you are all final year students, so you all already read about what is HIV, but I like to just short note about this. Come to the epidemiology. The HIV/AIDS pandemic comprises many separate independent epidemics, each involving a different mode of HIV transmission, and each epidemic has developed at the different time in the different countries. The following are the chief characteristics of each HIV pandemics observed by that is high prevalence among patients with STDs, high prevalence among intravenous drug users, and high prevalence among general population in some areas of Africa like Swaziland. The prevalence of HIV infected is nearly 33%, and South East Asia. What is the current global scenario? It is taken from WHO site. HIV continues to be a major global public health issue, having claimed 40.1 million, around 40.1 range this for life so far. And in 2021, 6.5 lakh people died from HIV related causes, and 1.5 million, that is 15 lakh people, acquired HIV. There is no cure for HIV infection. However, with the increasing access to the effective HIV prevention, diagnosis, treatment, and care, including for opportunity infection, the HIV infection has become a manageable chronic health condition, enabling people living with HIV to lead a long and healthy life as compared to the previous year. Mortality is much more. There were an estimated 38.4 million people living with HIV at the end of 2021, 2/3 of whom are in the African region. And now what is the Indian scenario? Nationally, there is estimated 23.49 lakhs HIV patient in 2029 with the adult HIV prevalence of 0.22%. Annual new infection are estimated at 62.9, around 63,000 in 2021 in India, and there is an estimated 46.3 decline in annual new infection rate at national level from 2010 to 2021. A decline trend is noticed in most of the states. Top 3 states with the most rapid decline are Himachal Pradesh, Tamil Nadu, and Telangana. An increasing trend is estimated in the northeast state of Tripura, Meghalaya, Arunachal Pradesh, Assam, Sikkim, Mizoram, and the Union Territory of Dadar and Nagar Haveli and Daman and Diu. Now some short about HIV infection. Etiology, all you already know, it is a human caused by human immunodeficiency virus, HIV. There is 2 types of HIV virus, HIV-1 and HIV-2. HIV-1, which has been classified into a major or M group and outline or O group. Group M consists of various subtypes A to N. There is some geographic variation in the distribution of this subtype. Like in India, there is a subtype C along with the subtype A, B, E. African region, there is a subtype A, C, and D. And other part of our world is a predominance of subtype B. HIV-2 is less frequent encountered, initially identified in the West Africa, has now spread to the many parts of Asia, including India. The clinical spectrum of both HIV first and HIV second induced disease is almost identical, except fewer things. Like HIV-2 is milder, progresses slowly as it has a longer incubation period, and is poorly transmitted vertically. mother to fetus. Coming to the structure of HIV, it is consists of two parts: outer envelope, that is a bilipid membrane in which viral antigens, that is glycoprotein GP140 and GP41 are embedded. The glycoprotein are responsible for the attachment of virus to the CD4 receptor of the host cells and subsequent fusion of the virus envelope with the host cell membrane. Inner core is bounded by a protein coat and contain three important viral enzymes: reverse transcriptase, integrase and protease. This is a schematic diagram of HIV virus. You can see there is an outer bilipid envelope having the glycoprotein embedded within them, and there is a protein coat, and within the protein coat there is a enzymes along with the genetic material. So, coming to the pathogenesis of HIV, HIV is an enveloped RNA retrovirus. Why named as a retrovirus? It is named because of an unusual step in their life cycle: the synthesis of DNA from an RNA templates using a enzyme reverse transcriptase. Both HIV first and second infect the same target cells, that is CD4 positive T cells, monocytes, macrophages and dendritic cells including Langerhans cells, all which have the CD4 receptor through the same CD4 receptor. On entering the T cells, the virus integrates its RNA genome into the host cell genome by first transcribe this genome into the DNA and form a HIV provirus with help of enzyme reverse transcriptase. Provirus is then transcribed and translated along with the host cell DNA to synthesize the specific viral components, which eventually assemble to produce complete viral particle. At this time, antibodies against the virus are not present, that is, the patient are seronegative, but he is highly infectious as blood is teeming with the virus. So, this period is termed as a window period, because the patient is infected but test for antibodies are negative. That is actually a false negative. Though some variants are killed, HIV continue to multiply rapidly, infecting more and more CD4 T cells, and the clinical manifestation depend upon effect of immune system. This multiplication process is more rapid in case of if immunity is low, and slow if immunity is relatively strong. In the early period of immune destruction, there is a clinical latency, that is, a patient look healthy, and unless his blood is tested, he is not even suspected to be suffering from HIV infection. Over a period of time, as immunosuppression progresses, the patient becomes symptomatic. There are various modes of transmission. Most important is sexual intercourse, as it is a important STI, and beside that there is a blood transfusion with the infected blood and blood products, transplantation of organ tissue, and through artificial insemination, contaminated needle and syringe, vertical transmission, that is from mother to child, and nosocomial infection in hospital healthcare setting. Efficacy and transmission. The efficacy and transmission depend upon the route of infection. In case of heterosexual transmission, the male to female transmission is 2 to 17 times more efficient than the female to male transmission, because women have the larger surface area of mucosa exposed to their partner genital secretion during the intercourse as compared to the men. Period of contact of a female genital mucosa with the semen is longer during the sexual act, and semen infected with HIV contain a higher concentration of virus than the secretion from the female genital tract, and sex during menstruation and anal sex enhance the male to female transmission. Homosexual transmission is more efficient than the heterosexual transmission because of concomitant trauma. Vertical transmission, the rate of vertical transmission of HIV from mother to fetus varies between 20 to 40% and depend upon maternal factor, maternal factor including high maternal viral load, presence of other STDs in mother, and breach in placental barrier. Fetal factor includes genetic difference in fetal susceptibility, which lead to different immune status. Invasive procedures that breach the infant's or mother's skills, and type of delivery. A cesarean section may have a protective effect, but it is a debatable. Transmission through the breast milk. Infants are susceptible to the infectious infection because immaturity of GI tract due to reduced gastric acidity, then thin mucosa and microvilli, and deficiency of IgA secreting cells. And quantity of virus present in the breast milk may be significant if the HIV infection in the mother is of recent origin, or the mother is a case of full-blown AIDS. Rate of transmission through the breast milk depend upon period of breastfeeding, amount of exposure, infectivity of milk, that is viral load, being highest in early infection and full-blown AIDS, and specific susceptibility of infant, again, fetal factor. So a question arises, should HIV positive mother breastfeed their serodiscordant infant? So answer, in developing countries, there is a risk of not breastfeeding is a far outweighed than the risk of HIV transmission. And because of this, you may prefer the breastfeeding. But in developed countries, scenario is different, so you can avoid breastfeeding. However, the risk of transmission exceeded the potential benefit after the 2 to 7 months, especially after 6 months. So, after the 6 months, you need to avoid the breastfeeding. Comes to the natural history of HIV infection. Natural history of any disease refer to stage through which a disease passes if there is no intervention. The disease course of HIV infection from a time of initial infection to the development of full-blown AIDS is divided into the 4 stages. Primary HIV infection, which may be present as acute retroviral syndrome and symptomatic. Then there is a clinical stage first, which manifests as a persistent generalized lymphadenopathy or may be asymptomatic. Stage 2, which may manifest with unexplained symptoms, infection, oral lesions, and itchy dermatosis. Stage 3, there is a manifest with unexplained symptom, infection, lesion, with panic hematological changes. And stage 4 is a fluid-borne disease, and there is a wasting disease, infection, neoplasm, and neurological disease. This is a table showing CD4 relation of CD4 count with the various stages and typical duration. Acute retroviral symptoms, usually typical duration is 1 to 2 weeks, lasts for 1 to 2 weeks, and CD4 count range from 1000 to 500. Asymptomatic period, which is a very long period, and CD4 count range from 750 to 500. When the count is below the 500, is problematic, and there is a start of early symptoms. And in late, you can see advanced stage, there is a count below the 50. As the count goes low, symptoms become more, and stage become advanced. WHO staging for HIV infection given by in 2006. There is a primary HIV infection present as asymptomatic or acute retroviral syndrome. Initial stage 1, that is asymptomatic and persistent generalized lymphadenopathy. Clinical stage 2, unexplained symptoms, including unexplained moderate weight loss, infections, recurrent respiratory tract infection, herpes zoster, fungal infection, oral lesions like recurrent oral ulceration, angular cheilitis, and itchy dermatosis like papillophoratic eruption, and so severe dermatitis, especially resistance to treatment. Condition where the presumptive diagnosis can be made on the basis of clinical signs or symptoms simple investigation, that is unexplained chronic diarrhea greater than 1 month, unexplained persistent fever, or unexplained severe weight loss, or with the presence of infection, severe presumed bacterial infection, pulmonary tuberculosis diagnosed in last 2 years, oral lesions like oral candidiasis, oral hairy leukopenia, acute necrotizing ulcerative stomatitis, and condition where the confirmatory diagnosis is necessary, unexplained anemia and neutropenia or thrombocytopenia, all greater than 1 month. Stage 4 condition where the presumptive diagnosis can be made on the basis of clinical signs and symptoms, HIV Vashti syndrome, infection, like cystic pneumonia, recurrent severe red blood cell bacterial pneumonia, chronic hepatic ulcer, esophageal candidiasis, extrapulmonary tuberculosis, neoplasm like Kaposi sarcoma, and neurological disease like central nervous system, toxoplasmosis, HIV encephalopathy. Where the condition where confirmatory diagnosis testing is necessary include bacterial infection. So as a stage in advance, severity of the infection and all condition become worse. So bacterial infection, disseminated non-tubercular mycobacterial infection, recurrent non-typhoid or salmonella septicemia, fungal extrapulmonary cryptococcosis including meningitis, candidiasis of trachea. There is a development of invasive candidiasis, there is an oral candidiasis, along with oral candidiasis. Viral infection, visceral herpes simplex infection, cytomegalovirus infection, progressive multifocal leukoencephalopathy, protozoal infection like cryptosporidiasis, isosporiasis, atypical disseminated leishmaniasis, neoplastic lymphoma, invasive cervical carcinoma. So disease progression of AIDS in HIV infected, there is a suspected disease table. Typical progression occur in 70 to 80%. Usually take 8 to 10 years to develop. There is a rapid progression also, which in which clinical latency period is very short or absent, and include 10 to 50%, and long-term non-progressor, in which clinical latency period is indefinite, range from around 5%. Coming to the syndrome, acute retroviral syndrome is a manifestation of primary HIV infection, occur usually 2 to 3 weeks, range can be range from 3 to 6 weeks after the infection. Incidence through experienced by 80 to 90% of HIV infection, but is only infrequently recognized due to HIV infection because it usually presents as a flu-like illness. And clinical feature illness lasts for 1 to 3 weeks and manifests as symptoms like fever, pharyngitis, vomiting, headache, arthralgia, and myalgia. There may or may not be a cutaneous manifestation and usually present as a maculopapular rash with mucosal ulceration with or without crawling there. Mouth is vaginated. There is an involvement of lymphoreticulaar system can present as a lymphadenopathy or splenomegaly, and neuropsychiatric manifestation like encephalitis, neuropathies, Guillain-Barré syndrome, and others, and psychosis. The rash typically manifests as asymptomatic macula and papules on the face and upper trunk, although the eruption may be more diffuse or pruritic. Urticaria and pustules can also be reported, and the symptoms generally last on average 2 to 3 weeks and resolve gradually as the level of plasma viremia decrease. So acute retroviral syndrome is basically because of initial viremia. The presentation of acute retroviral syndrome provides a valuable opportunity for the early diagnosis of HIV infection disease during a particularly critical time when the level of viremia and therefore degree of infectivity are the extremely high level. But unfortunately, this diagnostic opportunity may be missed if the clinical suspicion is not sufficiently high. The clinical image showing a xanthoma of acute retroviral syndrome. There is a discrete erythematous macules and papules on the trunk and arm. Associated finding were fever, scrotal ulcer, erythematous macula on palate, and lymphadenopathy. We can do an investigation. Hematological initial lymphopenia is followed by lymphocytosis, depletion of CD4 count with CD8 lymphocytosis, presence of atypical lymphocytes, usually lasting 1 to 3 weeks. You can do viral marker, HIV RNA, P24. HIV detection HIV RNA is very sensitive but expensive. P24 antigen detectable in 30% of patients with acute retroviral syndromes. And viral culture can be done, but technique is dangerous and labor intensive and not sensitive. Serology can use serological test, but may be negative in early illness because of that window period. And anti-HIV IgM is detected earlier than IgG. And then there is a phase of asymptomatic infection which can present with or without persistent generalized lymphadenopathy. Defined as an enlarged lymph node and among at least 2 non-contagious sites other than involvent nodes. Clinical feature: patient is clinically asymptomatic, is often diagnosed during the screening of for the blood or organ donation and or during routine checkup. And on examination, patient may have persistent generalized lymphadenopathy, and there is no prognostic value, however, for this, though disappearance of these lymph nodes may indicate onset of symptomatic HIV infection. Early symptomatic stage of HIV infection, so previously known as AIDS-related complex, and though patient look healthy, but a certain manifestations start to develop, including various autoimmune disorders and infections. And autoimmune disorders like idiopathic thrombocytic porphyria, Guillain-Barré syndrome, chronic demyelinating neuropathies, polymyositis. Infection like herpes zoster, oral candidiasis, oral hairy leukopenia, and pulmonary tuberculosis. Then there is a advanced stage, and there is a standard WHO case definition for AIDS surveillance. Advanced stage is a stage. An adult or adolescent greater than 12 years of age considered to have AIDS. If a test for HIV antibody gives positive result and one of the more of the following conditions are present: greater than 10% body weight loss or cachexia with diarrhea, fever, or both, intermittent or constant for at least 1 month, not known to be due to condition unrelated to the HIV infection. Other cryptococcal meningitis, pulmonary or extrapulmonary tuberculosis, candidiasis of esophagus, clinically diagnosed life-threatening or recurrent episode of pneumonia without etiological confirmation, neurological impairment that's sufficient to prevent independently daily activity, known to due to condition unrelated to HIV infection, invasive cervical cancer, and Kaposi sarcoma. So, if these are and along with the positive antibody results and one or more of the following present, then you can consider as an advanced stage of HIV, that is AIDS. Advanced stage of HIV is AIDS. From a dermatological point of view, clinical manifestation of these stages can be classified into the non-dermatological and dermatological. Non-dermatological is a manifestation, as I already discussed. And frequent infection seen in AIDS patient is pneumocystic gyrovascular infection, chronic cryptosporidiosis, toxoplasmosis, intestinal strongyloiditis, isosporosis, candidiasis, invasive candidiasis, involving the esophagus, bronchi, pulmonary, cryptococcosis, histoplasmosis, mycobacterium, avium complex infection, cytomegalovirus, chronic mucocutaneous or disseminated herpes infection, and progressive multifocal mucoinflammation. This is taken from fluids. There is the age-defining condition of HIV infected individual if present in an individual greater than 13 years of age. Again, these are candidiasis, cervical cancer, coccidioidomycosis, cryptococcosis, cryptosporidiosis. So these are encephalitis, herpes simplex, Kaposi sarcoma, lymphoma, mycobacterial tuberculosis, sites, avium complex, pneumocystic gyrovascular pneumonia. Coming to the dermatological manifestation of HIV, the cutaneous lesion of HIV infection can be broadly classified into infectious and non-infectious. So cutaneous infections including, before starting, just to remember all the basic idea of HIV infection in the advanced phase, immunity is low. So all the disease manifest as a severe way, tend to develop in the severe way and tend to reconstitute to therapy, and usually can present as a atypical presentation as well. So these are basic ideas. It's and coming to the infection. So dermatophytosis, cutaneous infections of dermatophytosis tend to become more widespread and resistant to treatment. Very common, chronic, recurrent, multiple lesions. Typical manifestation of can present typical manifestation of arteria incognito, and important finding is proximal subungual onychomycosis. Candidiasis tend to develop more common cutaneous infection and used to become invasive and manifest as oropharynx, esophagus, bronchial, genitalia, and airports. Staph infection, severe and recurrent. Bacillus angiomatosis indicate advanced HIV disease. Herpes genitalis tend to be chronic and recurrent. Normal course initially, but later become chronic. Herpes zoster initially normal course, later again become recurrent, multi-dermatomal involvement and disseminated. Molluscum contagiosum can present as a larger numerous lesions, can present as a giant molluscum, atypical lesions. Hemopapilloma virus, larger and more numerous, and Epstein-Barr virus cause oral-hairy leukopenia. Oral-hairy leukopenia resemble a leukopenia but has a vertical corrugation and located lateral aspect of. So these are some clinical picture showing herpes zoster in expression necrotic presentation, necrotic lesion with multi-dermal presentation. The molluscum in the AIDS patients, many lesions develop on the face, and these are picture of giant molluscum. You can see there is a multiple large lesions of. These are extensive tinea. However, nowadays this is type of extension is even normal in immunocompetent patient nowadays. But usually occur in some immunocompromised condition. This is a cryptococcus in a child with congenital HIV and AIDS. Pink plaque with crusted erosion on the face. These are disseminated histoplasmosis in AIDS, a young woman from South Africa, advanced untreated HIV patient. Present with the cervical adenopathy and disseminated skin color papule, which some become pustule and ulcerated. So there is a development of ulcerated nodules of various size. Oral hairy leukopenia is corrugated, that is hairy white lesions on the site of the tongue caused by opportunistic infection of Epstein-Barr virus on a systematic background of immunodeficiency, almost always HIV infection, but can occur in other immunocompromised states as well. This condition is not considered to be a true idiopathic leukopenia since the causative agent has been identified. Crusted Norwegian scabies. Again, like the Norwegian scabies tend to develop in many immunocompromised states, including the HIV. So HIV-infected patient with advanced disease can experience a variant of scabies known as crusted Norwegian scabies, which characterized by generalized scaling and there is a hyperkeratotic, ill-defined hyperkeratotic plaques. There is enlarged hyperkeratotic crusted plaques and Norwegian scabies. The thick and horny layer is riddled with the numerous mites. I already take this class about this. So there is numerous mites and hyperkeratotic plaques. So that nearly section show several parasites. Why there is a lot of mites? I already take class. Anybody remember? Okay, this is your homework. Again. The film, okay. Vessel angiomatis is caused by Botaniella anceli or Botaniella pintana, occur most commonly in HIV patient with CD4 T cell count less than 200. Clinically, the cutaneous lesion of Bacillus angiomatis are red to violaceous, dome-shaped papules, nodules or plaque that may resemble the cherry angioma, pyogeography or Kaposi sarcoma, although many atypical appearances have been reported. Tuberculosis is the most common opportunity infection of HIV, but cutaneous manifestations are relatively rare, even in immunocompromised population. Many forms of cutaneous tuberculosis are most reported, those associated with the low level of immunity, including multi-scleroderma, gummatous tuberculosis, and especially cutaneous biliary tuberculosis. Candida colonization is oropharynx is common HIV infection and reported in up to 90% of individuals with advanced disease. Clinical pictures showing Bacillus angiomatis making Kaposi sarcoma, subcutaneous nodule. Now the non-infectious condition, papillophatic eruption or pruritic papillary eruption. It is a chronic eruption of papillary lesions of skin whose etiology is unclear. Chronic recall reaction of mosquito bites. There is a escalated hyperkeratotic hyperpigmented papules at extremities and lower back associated with the severe itch and refractory to the treatment. Between 11 to 45% of Chinese patients present with papillophatic eruption and believed to a marker of worsening immunosuppression and is more commonly associated with CD4 lymphocyte count less than 50. Kaposi sarcoma. HIV-associated Kaposi sarcoma is 90%, 5% in homosexual or bisexual men, and associated with human herpes virus 8 infection. And a symptom sign of respiratory and GIT tract involvement based on respiratory GIT tract involvement. In the classical form, they develop on the distal lower extremities, and cutaneous lesion may progress through the 3 stages. Initially, there is a macular stage. There is a valiceous patches of discoloration, known as promontory stage sign. Plaque stage, lesion become infiltrated and confluent, and there is a tumor stage. There is a solid red purple nodules of form present with a vascular slit appearance. So Kaposi sarcoma remain one of the most common HIV associated malignancy worldwide, even with the reduction of incidence because of ART. Recently, a novel group of HIV infected patients has been identified that develop a new onset Kaposi sarcoma while already were largely suppressed on ART. HPV-induced dysplasia and squamous carcinoma are more common in the HIV-infected men and women than the general population. The high burden of men who have sex with men. Screening for anal and cervical dysplasia is particularly important for the HIV positive patient. And other neoplastic conditions, cutaneous lymphoma or other non-keratinocytes cancer are also more prevalent in the HIV positive patient. Primary cutaneous lymphoma in HIV patient tend to be aggressive rather than the indolent, with survival often less than 1 year. HIV Kaposi treatment in the case of mild to moderate disease, immediate ART initiation, while in the case of severe or symptomatic Kaposi sarcoma, along with the ART, you need to start the systemic chemotherapy. There is a WHO definition of mild to moderate and severe. In mild case, confined to the skin or lymph node, no symptomatic visceral disease, no significant oral disease, or edema of affecting function, not functionally disabled. While in case of severe symptomatic visceral disease, extensive oral Kaposi sarcoma lesion painful or disabling tumor associated with the facial, genital, or peripheral edema, life-threatening or functional disability disease, or progressive or persistent disease despite ART. Eosinophilic folliculitis not a infection. Don't confuse with folliculitis. It frequently occur in associated with HIV disease. Eosinophilic folliculitis present with the sudden onset of disseminated follicle-centered pustules, typically on the tongue and less commonly on face. Other conditions like psoriasis, plaque psoriasis is still most prevalent variant in HIV associated with psoriasis in the United States, but the presence of atypical presentation like rheumatoid psoriasis, SIBO psoriasis, reactive arthritis with a keratoderma blindoscum and long-term manifestation, acute onset of severe psoriasis, severe exacerbating of resistant psoriasis, and psoriasis with multiple morphology in a single patient should raise the concern from the contaminant HIV infection. Seborrheic dermatitis in the general population, the prevalence of seborrheic dermatitis was around 3 to 5%, but in the HIV patient, prevalence of seborrheic dermatitis become higher up to around 80%. And both prevalence and severity tend to increase with worsening of immune status. HIV patients are often refractory to the standard seborrheic dermatitis treatment, and they experience frequent treatment failure and recurrence. Now, medication-related cutaneous manifestation. There are nearly 100-fold increase in adverse cutaneous drug reaction in the setting of HIV or AIDS. Sulfonamides and penicillin are most common cause of these reactions. Morbilliform eruption are far most common manifestation, accounting for approximately 75 to 95% cases of all adverse cutaneous drug reaction. Urticarial and endophthalmic lichenoid drug eruption, vasculitis, and fish drug reaction are also reported. And in one study, incidence of 10 toxic epidermolysis in HIV-infected individual was found to be 375 times more greater than that is in the general population. Clinical picture showing 10 in the HIV-infected patient. Now, adverse effect related to the antiretroviral drug. So, most of the drug can cause, there is also classification, NRTIs. So, hypersensitivity with the rare instance of SGS10, systemic hypersensitivity reaction up to 8% of patient, associated with HLA B5701, leukocytoclastic vasculitis associated with adenocyte, abacary associated with systemic hypersensitivity reaction, hyperpigmentation of nail bed, palm, sole associated with emtricitabine, hyperpigmentation of nail including multiple longitudinal and transverse banded, diffuse hyperpigmentation of skin and oral mucosa, hypertrichosis, it is all associated, and leukocytoclastic vasculitis. So with zidovudine, lipodystrophy with stavudine and zidovudine, paronychia with nail-fold pyogenic granule associated with lamivudine and zidovudine. These are also FITS. There is a table in FITS factory. You can see. And an RTI, hypersensitivity again, lipodystrophy with lamivudine. Protease inhibitor, again hypersensitivity, lipohypertrophy associated with denavir, xerostomia, alopecia, these are associated with denavir, ritonavir associated with spontaneous bleeding and hematomas formation, and sequinavir associated with rare cases of FD. Fusion inhibitor, again systemic hypersensitivity, but in less than 1%. Integration inhibitor, Puratus, a rare case of skin hypersensitivity, and CCR5 antagonist, usually associated with systemic, not with the cutaneous manifestation. This is also classification, so you can see the classification: NRTI, NRTI, fusion inhibitor, integration inhibitor, and CCR5 receptor antagonist. I hope you all read in medicine already, as you are all the final year students. Then there is an immune reconstitution inflammatory syndrome, IRIS. Immune function is as the immune function is restored in HIV, the previously unrecognized or tolerated antigen may lead to the strong stimulation of immune response, and previously tolerated antigen may lead to the reverse and inflammatory reaction in the setting of immune reconstitution following the treatment of ART. So after the ART, immune status become strong, so there is a tendency to develop the reaction to the antigens which cannot develop initially because of immunosuppression. Both inflammatory condition and infection can be flared in this setting. High viral load and low CD4 counts at the time of initiation of ART are risk factors, and reported up to 20% of patients receiving ART, and usually occur in the first 2 to 3 months following the initiation of ART. There is a criteria in FIDS. There is a major criteria: atypical presentation of genetic infection, decrease of plasma viral RNA at least 1 lakh copies per ml. Minor criteria include increased CD4 count, T cell count, increased immune response specific to the relevant pathogen, spontaneous resolution of disease without specific antimicrobial therapy, continuous inferiority. However, I can't find how many major minor criteria required. This syndrome must be differentiated from HIV patient non-headed to ART and progress to the HIV, antimicrobial resistance, and tachyphylaxis. Most IRIS reactions are self-limited. Clinically significant dermatological reaction that may lead to the patient non-adherent may be treated with prednisone oral steroid, that is up to 1 mg per kg, which need to rapidly taper. One notable exception is Kaposi sarcoma, where the systemic corticosteroid may lead to worsened outcome. And in case of life-threatening reaction, may require the ART interruption as well. Now there is some correlation between the various manifestation and CD4 counts. In greater than 500, acute retroviral syndrome, herpes zoster, non-disseminated, and seborrheic dermatitis. When count is between 500 to 250, there is a dermatophyte infection, recurrent and persistent oral candidiasis, and oral hairy and herpes zoster become disseminated. And when the count below 200, there is a development of bacillus angiomatosis, hyperkeratotic, that is gastritis scabies, cutaneous miliary tuberculosis, folliculitis, herpes, chronic herpetic ulcer, idiopathic pruritus, invasive fungal infection, Kaposi sarcoma, giant molluscum with the large lesions, and papular pruritic eruption of HIV. Again, these from Fitzpatrick, all table, most table are from Fitzpatrick. You can go there and see the tables. Mucocutaneous disorder that are the indicated for the HIV sero testing. There is some manifestation which are highly indicative of HIV infection, including assumption of acute retroviral syndromes, proximal subungual onychomycosis, herpetic ulcer of more than 1 month, oral hairy leukopenia, Kaposi sarcoma, eosinophilic folliculitis, and multiple facial molluscum, giant molluscum, and papular pruritic eruption of HIV. These are highly indicative. Strongly associated is any sexual STD. Because of that, all STD need to do test for HIV. Herpes zoster, especially disseminated, sign of in the IV drug users, and candidiasis when become invasive, and may be invasive or recurrent. And some conditions may associate with HIV infection, including general persistent general lymphadenopathy, seborrheic dermatitis, and new onset psoriasis. Okay, now rest of the part you guys know already, testing and treatment. So I'm going to read it fast. So there are some screening tests, test for HIV specific antibodies, screening test, supplementary test, including ELISA rapid test, supplementary test including Western blot, immunofluorescence test. Then there is a confirmatory test including viral isolation, HIV specific antigen P24, PCR for RNA copies. Laboratory test, you can see various tests and their window period and their role in diagnosis. Again, it is for FITS. So ELISA and P24 for screening. Western blotting are confirmatory viral culture. Serological test, two types, one screening and supplementary. And screen test again, two type ELISA, enzyme linked assay. There is a comparison between ELISA and rapid test. Principle of enzyme based, it is a color indicator. Highly, initial cost is highly, while rapid tests do not require complicated operators, running cost low, but rapid tests require high cost. Usually screen test is used for emergency clinics, facilities and trauma centers. Immediate blood screening of blood donors have to be done, and time required 60 to 90 minutes. This is 30 minutes. Interpretation of screening test, there is an algorithm 1, 2nd, 3rd. In the algorithm 1, we do for screen donors, for the blood donor patients. You can screen for this algorithm 1. So you can test by highly sensitive but cheap enzyme assay. If become negative, blood can be used. If positive, then discard. Algorithm 2 is used for serosurveillance and algorithm 3 used for diagnostic purpose. In 2, you have to after the highly sensitive cheap enzyme assay followed by specific ELISA assay. And when positive, then consider as HIV positive. And for the diagnostic purpose, there is a 3-step. Initially, there is a sensitive enzymatic assay, but cheap, then specific, and then another 3rd test, specific plus sensitive enzymatic assay performed, and after that, only consider as a positive. If any of 2 become negative, consider as a HIV negative. So these are confirmatory tests including detection of viral RNA in PCR, detection of HIV antigen. Detection of P24 antigen is useful in the following situation, especially in the window period. Detection of HIV infection in newborn, and test is not very sensitive because of antigen is complex with P24 antibody. But this can be overcome by preliminary and acid hydrolysis of serum sample. And viral isolation, of course, is a confirmatory test, 100% specific. Treatment, I am not going to very detail of treatment. These are drug classification. Indication for starting antiretroviral therapy. Asymptomatic when the count hit 50 and viral load 10,000, you can differ, but when the RNA copies become more than 1 lakh, can start hard. And but if CD4 count is less than 350, then RNA copies value is not important, and any value you need to start the hard therapy. Or the symptomatic HIV disease, you not require CD4 count. So in case of asymptomatic, CD4 count is less than 350, you have to start. And in case of symptomatic, all the symptomatic, regardless of CD4 count, you need to restart hard.